Good afternoon, everyone. Welcome to RC Psych Dean's Grand Rounds on addressing the dementia gap and how we could use the primary care settings in low and middle income countries to leverage this gap. We'll give a few more minutes for people to join in. And in the meantime, if you can complete the poll, we would love to hear from where you're joining us today. So a special welcome to all our overseas delegates. We have about 550 people registered to this webinar today. Give it a few more minutes. So we have an excellent lineup of speakers today. We'll invite all our speakers to join us towards the end for a question and answer session and a panel discussion. So please post any questions that you have in the Q&A box. Try not to post them in the chat and put them in the Q&A box. And we also have the chat function to discuss and keep that interaction ongoing. So this session is being recorded, and the recording will be made available to watch later on demand for those who are not able to attend this live. So all the registered delegates will receive an email when the recording is ready. And we also have some resources that will be uploaded alongside the recording on the RC Psych Dean's Grand Rounds webpage. So all the speaker slides will also be uploaded alongside these resources, and the certificates of attendance will be sent out within a week of the webinar to all those who have attended this session live. So welcome again, and we're really pleased to have you all in this session. And I'm really looking forward to this excellent lineup of speakers today, and it's a very important and interesting topic that we have. So Catherine, can we have the next slide, please? So I just want to introduce a little bit about the RC Psych Dean's Grand Rounds. So it's a very innovative medical education tool that is the vision of our RC Psych Dean, Professor Subodh Dave. So the Grand Rounds focuses on understanding a problem or an opportunity for change in clinical practice, and using 4 different lenses, really. So trying to understand this problem using a patient story, a patient experience, and then the academic evidence to back this up, and the contextual data in this area. And then thinking about how we can bridge this evidence practice gap using a quality improvement approach. So the aim is to embed lived experience in clinical practice, and also to use data to drive change, really. So these sessions are being supported by the Conference and Advanced Learning Committee, the CALC, at the Royal College of Psychiatrists, and our lead on these sessions. So we encourage use of social media. So we are on Twitter. So please use the hashtag Dean's Grand Rounds and tag RC Psych if you're tweeting about this webinar. So without any further delay, the next slide, please. Catherine, yeah. So as I mentioned earlier, we have the 4 elements of the Grand Rounds, and we'll try to look at this problem of the care gap, the dementia care gap in low and middle income countries using these 4 lenses. And then we have the Q&A session. So I'm going to hand over to our excellent chairs, Dr. Victor and Dr. Sanya. Victor and Sanya are they are the co-founders of the World Network of Psychiatric Trainees, and this is an excellent platform for trainees all over the world and early career psychiatrists to network. So this session has been organized in collaboration with World Network of Psychiatric Trainees. So over to you, Victor and Sanya. Thank you.
Thank you very much, and good afternoon from New York City. I'm Victor Pereira-Sanchez. I'm originally from Spain and have been in New York for a few years. I'm a psychiatrist specialized in both general adult psychiatry and child and adolescent mental health and psychiatry. I currently work full-time as a program director of global fellowships at the Stavros Niarchos Foundation Global Center for Child and Adolescent Mental Health at the Chalmine Institute. And also I'm the founder and executive director of the World Network of Psychiatric Trainees, and in these later capacities where I'm speaking here in the WNPT. And I'm very grateful to the Royal College of Psychiatrists, and especially to Deepa for having this initiative and helping us organize this session. Very grateful to Dean Professor Subodh for hosting these sessions and also for inviting us, and to the technical team, to Catherine, to Charlie, and to everyone at the Royal College. Very grateful to my co-chair, Sanya, and to the speakers. I'll introduce, Sanya and I will introduce everyone very briefly and then listen to them because they are the protagonists. And also very grateful to all of you joining from all over the world. The World Network of Psychiatric Trainees has around 400 members in 30 to 50 countries all over the world, especially in low and middle income countries. We were founded in 2018. And we are very pleased to support the Royal College of Psychiatrists and other organizations, but especially here, the Royal College, in their efforts to showcase clinical care gaps and needs and opportunities, especially in low and middle income countries. And we are also very pleased to showcase the strength of our network is our members that are early career psychiatrists, trainees from all over the world. So we are very pleased to showcase colleagues and to bring promote discussions that are needed, especially in places like New York, London, or other places in high-income countries where many of you are based. We may forget about the needs and the gaps in low and middle income countries. So I'm going to introduce a couple of speakers in the panel. And then my colleague Sanya will introduce the other. So first, and very briefly, Dr. Djibril Moussa. He's the first and only psychiatrist in the north of Somaliland. It's a region in the Horn of Africa. It's a country in the Horn of Africa. And he's currently learning more in order to serve better his population. He's now temporarily in San Francisco as a global Brain Health Institute fellow. And he's specifically learning and doing research in dementia in low and middle income countries. And then I'll introduce as well my colleague Margaret Ojeahere. She's a psychiatrist in Jos city in Nigeria, and she's been championing global mental health, and she's been a great collaborator of mine. She's receiving a lot of awards, but more than anything, she's been doing an amazing job in Nigeria and in Africa. And I'll pass it over to Sanya.
Good evening, everyone, and thank you, Victor. My name is Sanya Virani, and I am the Associate Executive Director of the WNPT, our very wonderful network, which, like Victor mentioned, connects so many people across the world and from so many different countries. I just switched jobs, and in my current role, I serve as an addiction psychiatrist at the SUD recovery program at a VA system in Indianapolis. And I'm also an assistant professor of psychiatry, for the Indiana University School of Medicine. In my role prior to this, I worked with the University of Massachusetts Medical School as the Associate Program Director of the Addiction Fellowship. I'm also trained in forensics. I'm so pleased to be here with my colleagues. Since the reliance of everyone shifted during COVID to Zoom and other kinds of platforms and webinars, our WNPT has also taken advantage of these platforms to connect so many of you, offer fora on various topics of interest, get speakers from different parts of the world, coordinate these various time zones for people to make time and be available to meet, present, answer questions and such. One of which is happening today, and we're very thankful to the Royal College of Psychiatrists, especially Deepa Krishnan and Subodh to bring us on. And with that, I will not take up any more time, but I will introduce the third speaker. Dr. Victor Pereira already covered Djibril and Margaret. I will introduce Dr. Chandrima Naskar. She is an associate specialist of psychiatry at the Tata Main Hospital and an assistant professor in the Department of Psychiatry at the Manipal Tata Medical College in Jamshedpur in India. Let's get started, everyone.
Hello and good morning from San Francisco. I'm Djibril, and I will be presenting a case and caregiver perspective on dementia from an LMIC setting, and this will be from Somaliland. With introductions, I will just move to the next slide, please. The case presentation will be coming from a place named Burma, and I will be presenting a patient who is 69 years old, male, right-handed, married, living with his family member. He has high school level education and is retired. He's known local community leader, had history of a controlled hypertension. He came with his wife and his daughter to our psychiatric outpatient unit in Burma Hospital in Somaliland in June 2023, just before I flew to San Francisco. He presented with worsening memory impairment in the last 2 years. Next slide, please. And he was relatively stable 2 years prior to the presentation. He had, although sleep difficulty, moments of low mood and anxiousness prior to this presentation. For this, because of limited number of psychiatrists there, he went to a sheikh, which is a religious healer, to help him. He started to forget keys of the house and his car. He lost from home several times, although he was active with his community as respected elder and leader. He reported to have forgotten key meetings and commitments. In the first 6 months, he was becoming a stable factor, even among his community circles. Next slide. He had difficulty parking his car in the hotel parking lot where he used to meet with his community leaders. In the 3 months prior to the presentation, he even began to forget the names of his colleagues, and it progressed to his own family members. Although he's an observant Muslim, he forgot prayers, ways to do cleaning for prayers, eating food in the middle of Ramadan, as he was supposed to fast, forgetting it was Ramadan. And he starts to suspect people that they are attacking him. His wife reported that he observes ghosts on the wall that makes him really frightened. Next slide. In the last month prior to assessment, he began even to forget going to washroom at times when he had to clean himself, and then his wife and his children now support him to do his basic activities. His sleep got worse. He has difficulty falling asleep, and he asks his wife to give him breakfast at 2 a.m. and he says he wants to go to the market. They are forced to lock the house up now, and he gets angry and gets really agitated when the family tells him it's late in the night. He reports, and the family also reiterates, that he's very anxious in the weeks prior to the presentation. Next slide, please. In his past psychiatric history, there's no past psychiatric history, no previous history of suicide or homicide, no past psychotherapy or previous medications given for a psychiatric disorder, although he was given antidepressants for some time, no prior psych hospitalizations. Next slide. His primary care physician put him on imipramine 10 milligram BO or DNOCT to help him sleep. He was on simvastatin to control his blood liver problems, and his blood pressure is controlled by exercise and by diet. No known allergies, no other medical side effects that is known. Next slide. His past medical history, he has hypertension, dyslipidemia. There's no known surgeries or medical conditions. Next slide, please. He's the fourth people in his family. There's no family history of dementia, mental illness, or suicide. There's no other medical conditions that's known among the family or genetic diseases running in the family. Next slide. His personal social history: he was born in rural setting. He went to school and had to leave high school to earn a job. He worked in a manual workforce. He had no non-traumatic life experience. He's married over for 4 decades. He has children and grandkids. He's economically supported by his family with his stable socioeconomic condition. Next slide. Premorbid personality, there's no change in his premorbid personality. In his next slide. In his mental state exam, he appeared to be well dressed. He had, although poor eye contact, and his speech was normal, but had very low tone. He moved, he said, is fine, but on affect, it was also coherent and he looked to be okay. Perception, he had visual hallucinations, thought form was coherent. In the tone content, he had paranoid delusions, no suicidal or homicidal ideation. I will go to his MMSE in a minute, but in his societal cognition, he seemed to be disoriented to time, place, and person, and insight seemed to be intact. Next slide, please. This is the workup that we have done, and all became next. Although MRI was not available at the site of assessment, which is true in many low and middle countries, he had to travel to a city that was 120 kilometers away, and the MRI showed diffuse brain atrophy. Next slide. I'm really sorry that we don't have the mini-mental state exam. These are the medications he's currently taking, and his mini-mental status exam was the total was 13 out of 30. It was so low. And next slide. These are the main differentials we thought may be going on. Probably we thought that he had major neurocognitive disorder due to Alzheimer's disease. Next slide. These are the limitations in low and middle countries. There are no social workers or nurses to work on people having behavioral and psychological symptoms of dementia. In Somaliland, for example, there are no many MRIs, no biomarkers, no psychologists, no neuropathologists. There are no many psychiatrists or neurologists. Primary care physicians and nurses are available, as family medicine residence is the only specialist training now there. Community workers exist in other primary psych disorders settings, but not for dementia, which can be tapped in for practice. Next slide, please. This one, we're going to play the caregiver perspective of the son of the patient who discusses this status of living with dementia. Can we play the audio, please?
Used to be a very social person, outgoing, active member of the community, and all of a sudden things changed and we start noticing changes, a lot of change, like quietness, staying home, not remembering things, and then if he never used to like going out again, and he mostly spend his time in certain places like bed or sitting room alone, not talking a lot, and it start gradually getting worse. And after, when he goes out, he hardly comes back. Sometimes he used to pass the house, or sometimes he used to so people used to say they know him so very well, so people used to guide him and tell him, you pass your house, go back and stay. And sometimes they used to lead him and brought him back home. That's the first things that we notice on his change that happened to him. I did know dementia, not a lot, but I had some ideas of it's all about. I didn't know much, but I had some ideas about dementia, and I knew it was forgetting things and not really being the same person you used to be. It affected a lot my family, dementia, because it's a constant and 24/7. Somebody has to look after him. Somebody has to stay there, or doors must be locked, and his food, his shower, his everything. Somebody has to remind him, and it's really sad. And Dad used to be very, very active leader in the community, and he's not there anymore, which is very, very sad. Very social, very happy person at home. Everybody used to gather around and he start jokes and make laugh people. But now he's all quiet and not doing much. And all the other good things about him are slightly getting out, going away. In Somaliland context, it should people should get trained because they don't know much about dealing with somebody who's got dementia. It's really hard for the families, and like our family, when I talk about our family, it was something new that happened to us and we wasn't ready for it. And awareness and trainings and all of these would help, and some facilities might, if people get facilities and proper diagnosis centers and medications, would have been a great advantage. Would you prefer primary care physicians as they are very trained? Yes, I would care primary care physicians as there are very few trained psychiatrists and neurologists. Because dementia is going to be here forever and it's going to affect somebody again in every corner of the country. So, and people are not fully, if you know what I mean, people are not ready for it and they don't know how to deal with it. They don't know what it is. Some people doesn't even have a clue what dementia is. So it would have been really great to have primary care physicians as there are very few, and so they can tell people and then give the patient the care that he needs, and it would have been very helpful. And if I miss a point,
I will thank the caregiver, and I presented the case as they walked into the assessment. What we had to do was to reassess the patient, remove quarterbain, try to non-pharmacologically assess the patient's and neuropsychiatric symptoms, and through helping to change and is educating the family, we had to manage the patient without antipsychotic. And it went really sad, and the patient just progressed. As I am following up here some of the sessions and seeing his family members while away, but I'm learning that he's progressing horribly. This is a kind of situation that you see in a low and middle income country. I now pass the floor to my colleagues. Thank you, everybody.
Yeah. Hi, everyone. I'll be, in this part, discussing the dementia care gap in the LMICs, the extent of the gap, and the challenges. Next. So this is the brief outline under which I'll be covering this part. There will be a significant number of statistics and numbers, but please bear with me. Next. So the prevalence. As we all know, that dementia is currently already pretty high prevalence, with 50 million people suffering from dementia across the world at present, and the number projected for 6 years from now, that is 2030, is 75 million. And 63% of this 75 million would be inhabiting in the LMICs. The current prevalence of dementia in the LMICs is around 2 to 6%, but it's very difficult to identify a single figure or the exact extent of the prevalence because of the heterogeneity of the population and the different methods of assessment. Next. Also, economically, we do spend a huge amount of money on treating and managing dementia. Currently, it is around 818 billion across the world. And again, the projected amount is very high. That is by 2028, it will be more than $2 trillion. Next. In the LMIC, the challenges are kind of as follows, as I already discussed, that there is high overall patient load. There is delayed treatment seeking, as we saw in the patient discussed just earlier, that they waited for a very long time before the patient was brought to a doctor. So that picture is very, very common. The treatment seeking almost is at the latest phase of the illness when there is very little to offer. There is poor awareness in the community and even in the primary healthcare providers, and not just at identifying dementia level, but also about the information about what to do if they can even identify dementia. The poor coordination between primary and specialist care providers is another issue. Like in the previous patient, for MRI, the patient had to travel 120 kilometers. So that is the issue. Even when the cognitive problems can be identified at the primary care level, it is very difficult for the patient to reach to a center where proper dementia care can be provided. Other than that, the upcoming problem in the LMICs is that the society is changing in these countries. Earlier, till now, we knew that the Eastern countries or the LMICs differed from the West or the high-income countries in their family structure. So LMICs are known for the close-knit family, the close-knit society where the family provided the biggest care. However, now, because there are more and more nuclear families, more and more elderly living alone by themselves, this problem of having a caregiver available for the dementia patients or even persons showing mild cognitive impairment is on a decrease. Similarly, these countries have a poor social structure of having community nurses or community social workers who would reach out and provide care to these individuals. So the increasing nuclear families without a proper community service in place is making the care difficult. Next. However, the similar problem is also found in the high-income countries. So there are multiple studies which are reporting similar problems in the high-income countries like Canada and parts of Europe, where the rural residents, the ethnic minorities, and the individuals from deprived neighborhoods are facing similar problems. Next. So this is how an ideal dementia care setup looks like. It has to have early screening facilities, accessible memory clinic, integrated holistic care delivery system for the multi-morbidities, support group for the patient, infrastructure to provide respite care, daycare center, community activities to engage the patients, and also proper caregiver training and support. However, we know that this ideal dementia care setup is hardly available. So where is the gap? Next. So the gap is at different layers. It is not just one gap, but the gap comes at the level of detection. So dementia is under-detected, and even if it is detected, it is under-treated. And even if it is treated, it is hardly researched. And this gap comes at different levels of having less resource, having a deficit in focused training and focused research. Next. So in the gap in the resources, next. Let's come to the number of psychiatrists per 100,000 population. Why have I mentioned just psychiatrists? Because in the LMICs, especially, finding the numbers of other mental health workers is very, very difficult. So the global average of psychiatrists per 100,000 population is about 6.6, while in India, Nepal, and the other Southeast Asian countries, the average is somewhere around 0.5 to 0.7. In Africa, the LMICs parts of Africa, it is hardly 0.1. So that shows the huge lack of care providers. The ratio is even wider in the rural areas. Next. This slide has a lot of information, but what I would like to just focus on is that the average expenditure on mental health care in the high-income countries is already low. It is just 2.1% of the government health expenditure. In the LMIC, it is further low. It is 0.3 to 1.3%, which is markedly inadequate. Insurance coverage, while it is present in the high-income countries, In the LMIC, though certain insurance policies do say that they cover dementia care, but the exact parts of dementia care that is covered under the insurance policy is vague, and it leads to multiple insurance claim failures. Number of mental health professionals, I've already said that it's pretty low in the LMICs, and also mental health outpatient service per 100,000 population is also very, very dismal. I tried to find out the number of specialist geriatric psychiatrists or elderly mental health care workers in both the populations, but no clear data was available. The mental health atlas, which tries to find out various specific parameters for mental health care, does not give any specific data for elderly, while it does provide some data specific to child and adolescent. So we need to kind of try to find more data specific to the elderly population if we at least try to measure the gap. Next. There are certain WHO policies focused on dementia care. Next. But the National Dementia Plan has only been developed and implemented in USA, Canada, and South Korea. Data about the extent of implementation in the LMICs is yet to come. So though we have some policies in place, how those policies are being implemented, we still do not have much data yet. Next. Similarly, dementia care guidelines, this is from a slightly older data. So the WHO data of 2017 shows that only the two LMICs out of two countries out of the LMICs, that is Thailand and Iran, they have guidelines and protocols available and implemented. The other countries either do not have guidelines and protocols available, or countries like India, Nepal, Pakistan, and Myanmar, they have guidelines with protocols, but that has not yet been implemented totally in the public health level. Next. Coming to the gap in training, the care providers of dementia are of three kinds: the specialists, the dementia care specialists, the non-specialists, and family. Next. For the specialist training, it is difficult because, at least in India, the super specialization in geriatric psychiatry is very minimally available. Very few seats are available across the country. So similarly, there are very few specialists who are trained in dementia care. In the post-graduation level, while more focus is placed on the other severe mental illness and the common mental disorders, training is not particularly focused in identifying dementia and providing dementia care. Similarly, for the practitioners who are already in practice, there is no formal system of continuing medical education. Next. For non-specialists, like the community workers, though there are some primary healthcare professionals who are being trained in mental health care provision, but however, they come from a diverse education and experience, and they are underpaid and not specifically qualified for this specific work role of identifying dementia and providing them care or providing them information of where to go. Another big problem in LMICs is that the big language difference in India itself. Across the country, there are so many languages, it's difficult that one person who has been trained in one specific language going to another part and trying to provide a community level care, the language becomes a big barrier in communicating with the patient and the family. Next. For the family, as we know that in dementia, we are not just dealing with the patient himself or herself, but we are also dealing with the family and the caregiver. Unless and until we can train the caregiver to deal with the patient, it's difficult. So local language equivalent term for dementia is missing in many of the regions. Also, provision for family psychoeducation or how to manage the behavioral problems of dementia, how to treat these individuals in a family setup is grossly unavailable. Next. Finally, coming to the gap in research, there is a dearth of health professionals taking up research focused on dementia. Though Alzheimer's Association is devoting a huge amount of money to a significant number of projects that advance and support LMIC-specific research, and they are also pushing more and more publications out of the LMIC data. And this has helped. This has actually helped. In the 1990s, while only 10% of the epidemiological dementia research came from the LMIC, now in around 2009, it has increased up to 39%. Hope by now it has increased further, but still there is a gap of focused research. So the areas of this research gap, I'm going to highlight in the next slides. Next. The first thing, like someone in the Q&A had asked that in the previous patient, when MMSE was applied, whether MMSE has been adapted in the patient for Somaliland. Yes, so in many of these LMICs, we do not have locally validated tools in the local language, in the local context, and that becomes a major problem. Also, there is a significant lack of resources for any further assessment, like neuroimaging and biomarker is a thing of dreams in most of these areas. Next. Also, even if we get to do those, there is no population norm and no population norm for either the biomarkers or for the imaging data, which makes it difficult to compare. Next comes the need assessment of patient, like the kind of things that a person in the high income country is supposed to do on a regular basis, like using the technology, driving, etc. It's still not a common practice in all the LMICs. So the specific deficit of the patient, the need of the patient has to be assessed in a locally validated and socio-culturally appropriate instruments, which are still lacking. Pharmacological management for the cognitive symptoms as well as the behavioral and psychological problem become slightly difficult because RCTs which have been done in the LMICs, which can be applied in the guidelines of the LMICs, are lacking. Next. Similarly, for non-pharmacological management, we have minimal infrastructure, minimal trained professionals to cater the huge population. Like various research comes up with various methods of non-pharmacological management, but it's very difficult to apply those in these countries. And research for how to modify those so that they can be applied is lacking. Similarly, for carer intervention and institutionalization, there is very minimal research. Next. Prevention programs can be particularly important in these countries because it's resource poor and prevention can actually cut down the cost of dementia care. However, very minimal amount of work has been done on how preventive aspects of dementia can be taken up or implemented at a structural or as a policy-based method in these countries. Next. So finally, I would like to say that there are multiple barriers to care. There are some cultural barriers like poor understanding, normalization of age-related memory and cognitive problems. There is high stigma that going to a psychiatrist or going to a mental health professional is a bad thing. Then there is financial, because most of the people cannot afford to get care for their even medical illnesses. So getting care for cognitive decline is sometimes too much to think of. And finally, structural, that is the lack of availability, accessibility, and acceptability is something that we are fighting here. So finally, to summarize, I'd like to present the final slide. Next. So we have high population with increasing elder adult population. There is a low mental health professional to the population ratio, which makes the challenge more difficult. Even among those few mental health professionals, super specialists who are specifically trained in elder adult care and research is low. When we try to do some research, regionally focused research and treatment guidelines and policies are lacking. And because of the local lack of research, poor policy implementation and program monitoring becomes a consequence. And finally, what this leads to is poor patient and caregiver awareness and experience. So now I'd like to hand it over to my next speaker so that she can discuss some solutions to these problems. Thank you.
Thank you, Chandrima. Hello, everyone, and thank you for this opportunity to speak alongside my colleagues on a pertinent issue that has not received due priority for expedient action, nor has it gotten the attention it deserves as a public health issue. I'll be speaking on leveraging collaborations and technology for the dementia care gap in LMICs. Next slide, please. I have nothing to disclose. Next slide. I'll be using this outline in the course of my presentation. This is my tertiary institution where I work. Next slide. In the course of this presentation, I'll be using LMICs as an acronym for low and middle income countries. Dr. Naskar has taken us through the dementia care gap in low and middle income countries. However, it's important that I reiterate this because understanding the magnitude of the problem helps to give us Sorry about that. Okay, sorry about that. Okay, so yeah, I was saying that Dr. Naskar has taken us through the dementia care gap in LMICs. However, it's important that I reiterate this because we need to understand the magnitude of this problem as it will help guide tailored intervention. It has been established that the burden of dementia gap is huge globally and worse in LMICs, with over 60% of people with dementia living in these countries. And this population transition, demographic transitions, rather, population growth have been contributing factors to this. That's not news anyway. But what is saddening is that in sub-Saharan Africa, females are still saddled with the burden of bearing the burden of dementia care. Next slide, please. Although it may sound grim that dementia care gap is estimated to be 80 to 90% in most LMICs, it's also reassuring to know that 40 to 50% of people living with dementia could have been prevented or delayed using prevention approaches at primary care level. The next slide highlights the 12 modifiable risk factors for dementia and how it can be controlled. Next slide. This slide expatiates on the population attributable factors for these factors. And from this slide, we can see that risk factors with high population attributable factors, such as midlife hearing loss, education in early life, amongst others, can be targeted for dementia reduction. Next slide. But before we begin to examine the how LMICs are using this information to bridge the dementia care gap, let's take a brief look at the health patterns for dementia care in LMICs. In order to achieve better outcomes in dementia care, early diagnosis is critical. But unfortunately, belief systems and stigma are barriers to this. In Africa, like other LMICs, dementia care is primarily by family members, and formal care is usually the last point of call. It is usually when symptoms are profound that they consider formal care. This is not unsurprising when you consider the way they perceive the etiology of dementia influences their health-seeking behaviors. And the sad part is that a considerable number of people living with dementia and LMICs have been accused of witchcraft and have suffered gruesome experiences, while others have faced forms of abuse and ageism. It didn't help that for several decades, dementia diagnosis was considered the purview of specialists, psychiatrists, and neurologists. Next slide, please. So where are we now in addressing the dementia care gap? Do we reinvent the wheel? There are several evidence-based models of dementia care which have been adopted in high-income countries, such as integrated memory care, mind at home, hospital-based dementia care, and many others. And these have been shown to improve the quality of life of patients and their caregivers. While some will argue that there's no point reinventing the wheel, and they will encourage the adoption of evidence-based practices from high-income countries. And this sounds pragmatic, especially with the absence of guidelines for dementia care in LMICs. It's important to state that in adopting models, one should take into cognizance the unique circumstances of the patient within their communities. Central to the success and efficient use of these models for people living with dementia in LMICs is understanding that the family dynamics and the relationships within their communities. What may be more practical is to address low-hanging fruits, like reducing the dementia risk factors or controlling the dementia risk factors. With the advent of COVID-19 pandemic, technology has been embraced for elderly care, and we are seeing advancements in preventive, therapeutic, and rehabilitative domains across countries in varying levels. Nigeria and parts of Asia will be used as case studies for this presentation for the evidence-based intervention. Next slide, please. The goal in dementia care essentially is prevention and reduction of dementia, early diagnosis, and improved quality of life for the patients and the caregivers as well. So armed with this information and targeting the modifiable risk, as well as identifying the limitations within our resource constraint settings, we focused on local context and leverage on collaborative community-centered models. Collaborations are multidisciplinary, and we engage non-psychiatric physicians, family physicians, medical officers, and usually we have a geriatric assessment team. We also have community teams that include is also multidisciplinary. We recognize that as specialists, we do not have the numbers. We are very few, but we have the expertise. And so we leverage on that and train non-specialist personnel and volunteers. And we also partner with non-governmental organizations, faith-based organizations, and civil societies who have, these people have the numbers, they are large, and they're able to trace cases and follow up within the communities. We also work with, well, there are also several associations like the Alzheimer's Dementia Association in Nigeria, which is also focused on improving the quality of life of people living with dementia. Unfortunately, most of these activities go undocumented, and so there is a dearth of data on this. But what we see is that we have transitioned, please, next slide. We have transitioned from basic advocacy within our hospital settings, our clinic spaces, to dedicated dementia awareness programs in line with the WHO's 2017-2015 Public Health Dementia Plan. And we're having awareness programs across large communities, large platforms, seminars, webinars, involving policymakers and stakeholders. There's also increased awareness now, primary prevention, the push for lifestyle modifications, alongside other medical conditions. So it's not just, oh, you need to exercise, or you need to eat healthy, you need to reduce your alcohol and nicotine, or stop at all because of your heart issues. Now we're linking it up with brain health, and we're seeing results too. We're also engaging non-health specialists and allied professionals to diagnose, provide care, and even end-of-life issues within the communities. We have some philanthropies which have helped in building daycare centers and respite homes like the Tonyaneni in Ibadan. Even though formal care is still not something that's widely accepted, there is a change, a shift in the way people are beginning to view formal care for people living with dementia. One other area that is worthy of mention from Nigeria is the research-focused collaborations that incorporates community engagement. Although, next slide, please. Although research from LMIC is scanty, it is laudable that Nigerian researchers have contributed to several studies on genetics of dementia. We have several genetic epidemiology studies involving people living with dementia, and there's a collaboration. Usually it's in collaboration with other African countries and some of global north. There's one that I think is worthy of mention. That's the origin of Alzheimer's dementia in African Americans. And so there's an extension to Africa where they want to study ancestral populations in Africa. They want to understand the genetics and ancestral and clinical features of Alzheimer's dementia in Africa, and the allele transferability across populations. The interesting thing is that despite it being strongly biological, there is a strong community component where there's going to be advocacy, there's going to be community engagement and community involvement. And I think that is quite impressive. COVID-19 gave us, next slide. COVID-19 gave us a silver lining. Before then, telepsychiatry was considered alien for treatment in the elderly, and one-on-one consultations were preferred. I wrote together in collaboration with my colleague, we wrote on telepsychiatry and the elderly, and we are concerned that they will be exempted because a number of them had mentioned how they would rather have their one-on-one consultations. But in recent times, empirical evidence shows that in the face of present realities, a number of them now prefer virtual meetings because of stigma reduction, difficulty accessing care, the waiting time is eliminated, and the financial implications of transportation fares has also been removed. Technology is also used for training non-health specialists and non-health personnel and specialists in dementia care and education. That is the face of one of the very few psychogeriatricians in Nigeria. She uses technology to educate and raise awareness on dementia and other mental health conditions in the elderly. It's also believed that implementation of telepsychiatry will improve the recruitment and retention of people living with dementia, and also help in research purposes too. But the beauty of technology in the elderly is that it can just be a simple mechanism, a simple thing, and that's what the Sense Cog Asia adopted. Please, next slide. It is noteworthy that in some parts of Asia, Pakistan, India, and Bangladesh, a feasibility study of a hearing intervention to improve the outcome of people with dementia was carried out. It was done in, it leveraged on the high population attributable factors of modifiable risks of hearing impairment and dementia reduction. They adapted a non-pharmacological intervention for people over 60 years with mild to moderate dementia. And it involved the use of adapted hearing support interventions, hearing aids, and a home-based support from a practitioner, a trained personnel. The study was conducted in 3 phases, and India was part of it. Bangladesh was but the main study was carried in Pakistan. Findings from the study show that it's feasible, acceptable, and it has promising outcomes. It was adapted from an European version, and it buttresses the value of adapting effective interventions to suit local contexts. Also, it's a call to African researchers that we can also adapt this Sense Cog for Africans, and let's report our findings. It's been done in Europe, it's been done in Asia. Let's see what it is, what we're going to find in Africa. I saw someone write about how can we have more South-South collaborations. We need to write our stories, let it be told. While we acknowledge that we have made significant improvements in dementia care, next slide, in LMICs, it hasn't been without its roadblocks. And I've mentioned cultural, religious, and stigma, but it's usually the elderly are usually people who have retired. They have little or no source of income. They are dependent on their relatives. And insurance packages in this part of the world is absent or very, very infinitesimal. And so a number of the expenditure is out of pocket. So we see a huge economic toll on the family, and sometimes they get abandoned. Technology, yeah. We're also having erosion of the informal care system with urbanization, with migration. We're having, and people are getting more individualistic. So we're seeing that being eroded, and it's going to have its impact on people living with dementia. There's also the depleting manpower already. Very few personnel and specialists or psychiatrists or trainees want to come and specialize in psychogeriatrics because it's seen as something that is not very lucrative. I remember trying when I wanted to write my thesis in old age. I was studying the elderly. I was told that, why do you want to waste your energy on people who are already in the twilight of their age? So there's that ageism that even is experienced amongst us as not ageism, stigma that is experienced amongst us as clinicians or physicians. Okay, and yeah, technology is good. There's access to internet, but very few have access to this internet, except for the few brilliant ones. And I've mentioned that parts of Nigeria, in Asia, there are research going on, but the truth is, this research is siloed and they're just in pockets. It's still scanty. We need to get our stories out. We need to do more research. Next slide. This is just, next slide. This is a summary of what I've just mentioned. Next slide. So what are our future directions? We need to be more dedicated in carrying out those things, target modifiable risk factors, task shifting. We have to train more. The numbers are depleting each day. And then it might be necessary to incentivize personnel. We should incorporate dementia care into primary health care. This is very critical. There should be equity. We should support equity in access to dementia prevention. And then the adoption of the WHO Global Plan of Action on Dementia's target of diagnosing 50% of people living with dementia in 50 countries by 2020. Fund is critical. With everything I've said, if there are no fundings, we can't get research done, we can't get all this done. Next slide. Perspectives, because the conversation is still ongoing. And I believe that it's going to open more going to stimulate more conversations. So it's important that we keep identifying these gaps, as they will tailor the interventions that we're going to use to address the health needs of people living with dementia. It's not gainsay that the family is the bedrock of dementia care in most LMICs. While we push for equity in dementia care and remain optimistic for innovations that will improve the quality of life of people living with dementia and their family, we should consider culturally considerate innovations that are patient-centric, yet evidence-based, and leverage on collaborations and community-based services for prevention, early detection, diagnosis, and post-diagnostic care. Next slide. Thank you. Next slide. My references. Thank you.
Thank you very much, Djibril, Margaret, and Chandrima. These have been very quick, but also wonderful presentations, and we've been learning a lot. There's been a lot of interest. I've seen a lot of conversations in the chat, a lot of questions that I think mostly have been answered live, written. So apart from these questions, and we don't have much time, but maybe in 5 minutes, I also wanted to have your ideas, and especially maybe Djibril, that you are now temporarily like in the United States, so you have these both perspectives. That is not only what can we learn about here in the high-income countries, about low and middle-income countries, the challenges, but also what can we learn from how things are done there that can help us treat better patients with dementia in the UK, in the US, and in other high-income countries.
Absolutely. What we can learn is that we from low and middle countries have to first develop the interest to learn about dementia, about old age psychiatry, geriatric psychiatry, and neurocognitive neurology, and things like that. And what we can learn from low and middle countries is one thing: the structure of families, and how families are so strong in taking care of patients. That's something we have very strongly in the low and middle income countries, where the families are so closely netted. What we can learn from the global norms, particularly where I am here at UCSF, and what I have seen is how the system is improved from biomarkers, MRI, bed scans, FG-BET, neuropathology, neuropsychology, you name it, and the interaction between psychiatry, neurology, and an excellent outreach program that I have seen in San Francisco. And also what we can learn from the global norms, including where I'm training now, is how they develop the care plan. And we have very interesting community, call it the ECO care plan for dementia, which supports patients and caregivers, and also links them with the resource they need: housing, social workers, insurance, and things like that. And what we can also learn is how the research in dementia is moving amazingly strong. Like, I came to San Francisco and they were starting the first Lamivacab medications. And I saw, like, the program started in September, and I could observe how things could happen and how it is so promising that dementia research is improving at a very high pace.
Thank you very much. Sanya, do you want to give any remarks or showcase any questions from the audience or from yourself?
So thank you guys, first of all three of you, different perspectives from different parts of the world. So that's obviously very helpful and very informative. I have been monitoring the chat and obviously the Q&A, especially I see that people put in chunks of information about what they've done either in their own experience, their own maybe studies, a paper that they're referencing. I want you to know that that's not going unanswered, or, you know, I'm taking screenshots, we're noting this down. So thank you for that input, even the references that you guys provided, although they may not necessarily be questions. A few people we've just answered individually too. I didn't have a whole lot to ask the speakers. I think the audiences should partake in doing that. Thank you.
Thank you very much. And Yeah, I think it's all been covered already, but and we have to finish. But maybe just for a quick round about from our speakers, is like we've been hearing a lot about challenges, about potential solutions, but maybe if you can give like a one-liner or like two things of what would you like to see in your country or maybe just in your city, in your town, in the next 5 years to help address these challenges. So we can go Djibril, Chandrima, and Margaret. I'm finished with this. You're muted, Djibril.
I would like to see dementia being part of the mental health policy for Somaliland. Now we don't have it. My job and my commitment is to put all age, healthy aging, and dementia research onto mental health policy in my country.
Chandrima.
Yeah, I think what will be quite useful is focusing on dementia care and identification in the part of even the undergraduate curriculum, like in the MBBS level, like every other illness, the common illness that we see, if we start teaching the medical trainees from the very beginning that this is what dementia looks like and this is the basic things that we can do, I think that can make a big change.
Margaret.
So I hope that in the next few months to years that next few months actually that there will be the establishment and implementation of policies that include the elderly, not just for dementia care, but elderly with mental health challenges, incorporating them or including putting them into cognizance. And also, I am hoping that there will be equitable access to diagnosis and access to care for people, the elderly with mental health challenges. Yeah.
Thank you. Thank you very much. Passing back to Deepa to close the webinar.
Thank you, Victor and Sanya. And thank you to all the speakers. It was a fantastic session indeed. And I think there was so much of learning from there about the extent and the impact of this dementia care gap and some innovative initiatives to bridge that gap. So a big thank you to all of you for presenting and Sanya and Victor for collaborating to make this session happen. So I also want to take this opportunity to just point out that there's a link to the feedback form in the chat, and we use the feedback to learn and improve these sessions. So please take a few minutes to fill this feedback form. And a special thanks, just to finish off, to the Calc colleagues, Catherine and Charlie, who made this session so organized and supported this all along. And thank you to Professor Subodh Dave for his excellent leadership and vision, and in his constant support with these sessions. There's so much of learning from these sessions. On that note, I would like to announce the date for our next grand rounds, which is next month on 25th of April. And this is being hosted by the RC Psych Eastern Division and the RC Psych Perinatal faculty. So one that's hosted within the UK divisions and faculties. I'm hoping to see that many of you are able to join that. On that note, I would like to draw this excellent webinar to a close, and a big thank you to all the delegates who joined us from all over the world and took time to interact and learn from each other in this session. So thank you.
And many thanks to the patient and his family for sharing the story.
Absolutely. Thank you for that.
Thank you, everyone.